So really thank you very much again for this invitation. I really enjoy myself very much in Iași. And yesterday were really amazing, and the city is amazing. People are really amazing here. So first time to be Iași, but I know at least the next time this year when I will come back, and you will hear it at the end of my talk. So let's speak about a little bit on pancreatitis. And first I was speaking what to say about pancreatitis and how to put together my presentation. But because there are many young people as well, I would like to show you like a development, how we started building up pancreatology, and about a little bit history backwards as well, showing about a different kind of results, what we could achieve at the end. But before I start, actually, I just have to tell you that yesterday evening I found out a big event, because one of the most distinguished scientists ever received the Nobel Prize in Physiology and Medicine was George Palade. Because actually he invented the electron microscope, and then the very first time he used the pancreatic cells, and he was the one who isolated the ER and the first vesicle, and he described actually how these kind of cells can secrete enzymes. And not surprisingly, it completely boosts molecular biology, cellular imaging at that time. And not surprisingly, just 50 years ago, he received the Nobel Prize in 1974 for discovering the vesicle transport. And this is, even for all Nobel laureates, keep him in a very high rank. So giving a presentation as a pancreatologist in a George Palade auditorium, that's a privilege. So thank you for that. So let's move the next time. So what is really my vision is that if we, who was here yesterday know exactly what I mean, that science needs into healthcare. We need science in healthcare to have the best practice. We need to look at data, we need to reanalyze data, we need to make decisions on data. This is the only way we can do really big change in healthcare. So really my aim as a physician in a pancreatic unit, really to have a groundbreaking change in healthcare, and also as a teacher at CTM is the same in scientific education. So actually I was born in 1972 and started the university in Szeged. In 1990, finished it in 96, and I started doing as a project undergraduate students my research work in 1993, 31 actually years ago. So I divided my life to 4 phases. This was the very first phase, but what I learned actually from my life so far in the last 30 years, that there is only constant was in my life is actually the change. So in the first period, of course, I learned like basic research. I learned preclinical models. And after that, when it was at 99, when I already was a resident doctor for 3 years, I went to Newcastle upon Tyne with a Wellcome Trust Fellowship and learned really intracellular physiology there. And I learned how the different pancreatic ducts actually involved in pancreatitis. So this period in my life was really a learning phase. And when I came back, I also received a grant from the Wellcome Trust, which was so-called Initiative Research Development Award, which gave money to set up my laboratories at Szeged. I felt I will live all of my life in Szeged. I was born there, went to kindergarten, primary school, secondary school, university. So I felt Szeged is the best place and really a very nice place to live. So at that time, we started the basic PhD program. We had the money, we built up equipment, we started having PhD students. And during this period, this was really extremely successful by the young people. And by the time of 2008, we could reach really the best journals in gastroenterology, which was gut and gastroenterology. And I think I still think that there were much more luck in it. But in 2004, I was elected to be the president of the European Pancreatic Club, which I took the position in 2009 when I was only 37. I was far away the youngest president of the European Pancreatic Club. Usually this is coming after 60. So we took the possibility to organize international meetings in Szeged and went on. However, in 2011, what I realized, after we had so many highly important discoveries in basic science, that somehow we need to bring it for patients' benefits. And when I look at what is Hungarian pancreatology, we had no guidelines in Hungarian, we had no international visibility, we had only posters in conferences, we were not in the front line. And after I realized that the major problem is that our data is not structured. So without data, you can't do anything either in basic science nor in clinical science. So what we did, we established the Hungarian Pancreatic Study Group in 2011, completely on a desert, I must say. So there were nothing, and we actually established also an electronic clinical data system, and we started the clinical PhD program, which developed to CTM. You heard the presentation yesterday. However, unfortunately, the University of Szeged didn't feel that it must be a direction, and they didn't want to separate 8 beds only for pancreatology, for pancreatic researches. So that I felt, come on, what to do then? So at the University of Pécs, which is also a very good university close to the Croatian border, the director and the dean said, oh, Peter, we provide you everything. We give you the Department of Pathophysiology. You can rename it to Center for Translational Medicine. We will give you 8 beds at the Internal Medicine Department, and we give 125,000 euros to set up a translational center. Oh, so I went back to the rector at Szeged. I don't want to leave Szeged. I want to live here forever. They said, okay, you can live here, but we are not providing you anything about it. So what could I do? So I moved in 2016 to the University of Pécs, where the second period started. And there were 2 major things what we could do. One of them, which is highly important, we established the Center for Translational Medicine, which were growing, and you saw the results yesterday. But very importantly, we changed healthcare. Because usually in the healthcare you have nurses, resident doctor, and consultant. This is what we do in healthcare. But now, here we had clinical data administrator, patient coordinator, and PhD students. In my 30 beds unit, there are 27 PhD students and 9 clinical data administrators who are collecting the data, putting to structured database, and the PhD students are doing the analysis. And the results were really tremendous. We not only could publish paper in Nature Medicine, but this was at the University of Pécs, the department impact factor before we started it, and last year it was 701. So within a very short period of time, this could burst out. However, as my second part in my life, they also felt, no, we don't need to make it a bigger unit. You don't want to work with pancreatic cancer, so on. And that was the time when Béla Merkeli, the director of the Semmelweis University, said, Peter, I'm very happy to give you a 30-bed unit. I am very happy to give you a separate center for translational medicine. So why not to move then? So this was the third time when I moved them. So we established the Center for Translational Medicine. You get the presentation yesterday. And we established this 30-beds unit. We see around 2,000 patients per year, around 800 AP, which is really, really a lot. 36 hospitals from their ER unit referring the patients when they have acute pancreatitis to our centers. We have around 300-400 chronic pancreatitis also in the center, and around 500 pancreatic cancer. These are usually about the numbers. But I would like to highlight the importance of the data management, because without data management, you can't do clinical science. Why we need data? First, if you would like to improve healthcare, without data you can't. So you need to have key performance indicators. The second issue is, of course, if you are an academic person, you need to contribute to science and to the knowledge. So to contribute, you also need science, and to change policy, even at the university or in a national level, you need to do that. So with one data collections, you can feed 3 different aims. This is very important, that with one, you can triple benefits from the system. So what we do, actually, for all patients, we take the data to the electronic clinical data management system. So you will have at the end the structured database. And after that, we download it and we make figures. I will show you a couple of them, so visualize it on time. So we can, anytime in my computer, when I press the button, I immediately can see all data. But every month we are looking at how we performed in the last months in the clinic, and after we can make decisions actually in our unit. So for example, what kind of indicators you have? Just this is, for example, this is the total number of patients. This is like we saw like 1,073, the age, the mild, moderate, severe pancreatitis, male, mortality. So you can see that this is really a general cohort. But every 4 weeks, we're looking at every month what kind of changes, we can see. So this is, for example, 1 month's data as well. Here is the length of hospitalization for the patients. We also checked how many days they are spending in the hospital. So this is like checked as well. We also look at the different kind of etiology factors. Of course, in pancreatitis, biliary and alcohol and hyperlipidemia are the most important. However, we also look at about in which level the pancreas was. So if somebody has a first attack of pancreatitis, we call them AP. If somebody has 2 pancreatitis, we call them recidive pancreatitis. If they have 3 or more pancreatitis without morphological changes on the imaging, we call them early chronic pancreatitis. And the 4th category is the acute and chronic pancreatitis. So we divided the acute pancreatitis for 4 different entities based on whether the pancreas had earlier any kind of injury or not. So for example, this is also one of the key performance indicators. Actually, we measure, for example, the imaging. Whether the imaging has been done on the ER unit or not before we admit it to the system. So this is the numbers you can see. Usually the first choice is ultrasonography, but the ultrasonography is not cannot see the pancreas due to the gas bowels. We immediately send them to CT because it has to be visualized. You cannot take to avoid the pancreatitic patients without seeing the pancreas because you have to know the etiology. If there is maybe like you can see, it's a choledochus dilatation, you have to do the ERCP. If there is a tumor in the pancreas head, you have to put a stent in it. So you really have to visualize it. But we also check the ultrasonography, whether it was visible, not visible, and if it was not visible, whether the resident doctor asked for a CT or not. So here, and we look at about good management and bad management. Now we could change it. I saw the last month's data to 94%. So we really could improve the visualization of pancreas. We also collect about the usage of antibiotics. So I see every month how many patients antibiotics started. Unfortunately, this is like in Eastern Europe and Central Europe, usually 90%. Or 80–90% the antibiotic. We also look at how the patient started to be feeded because they have to get something. So carentia is no treatment any longer. So here you can see that how many patients got a nasogastric feeding and liquid oral, and we also look at that how many of them needed to change from nasogastric to nasojejunal feeding. Idiopathic follow-up. Also, pancreatitis is not like IBD, so this is not this kind of disease. However, 20% of the disease is recurrent. So very important when you discharge the patients that to do actions to understand the etiology, because this is the only way to prevent the action. So if finally it's turned out that there was a triglyceridemia or there was like you do endoscopic ultrasonography and you see that there was microstones in the choledochus, or you look at also the autoimmune pancreatitis, you can find a way. And it's very important that here is the idiopathic pancreatitic patients. And we did already these patients after we discharged them. We asked them, the outpatients department, the etiology check, and we could complete it, these ones. And 2/3 of idiopathic pancreatitis, if you do a searching after that, you will find why was that idiopathic. So we have like a patient's coordinator in our unit who, when the idiopathic patients went home, we asked them to come back for different examinations. So this is the way how we improve actually our units. For example, in our hospitals on Saturday and Sunday, we send the patients home. We discharge exactly the same way how we discharge on Monday or Friday. Because in the past it was on Friday, okay, let's wait until Monday. But sure, be sure. And we looked at how many patients we can discharge in the weekend. So sometimes happening that 6-7 patients going home on Saturday and Sunday as well. So if it's in acute pancreatitis, it's not a flat rate, the discharge and the admission, there is a problem. So I look at my colleagues every month. I have a list that who was in duty and who is not. So we immediately can improve. So how you can contribute, if you have a huge database, you can contribute with writing up the different articles. So we can publish many, many articles in pancreatology, not because we are different persons than anybody in this room, but because we have really a strong database. For example, one of was, which was fascinating for me, that this was in Szeged. I think it's very similar like here. When in the ER unit, there is a pancreatitis patients coming, and they are located to different departments, where there are places or where, you know, even in surgery, internal medicine, gastroenterology, ICU. And the other cohort was like what we built up also in Budapest, that we have a pancreatic center, so it doesn't matter where the patients come up. If the patient has acute pancreatitis, sending to an organ-based center. And what was actually amazing, that when we look at this really decrease, the high volume center can decrease the mortality severity, because the knowledge there really much better. So in the 21st century, I think all diseases should be treated in an organ-based level. It's much less cost for a hospital and much better patient care, and you can do science as well. Or the other issue was, you know, when we looked at about the Bishop score, which is one of the important score, where there were like 65 years showed that this could be a limit. We also looked at concerning the severity, comorbidity was important, but the aging, you can count it. But concerning the mortality, definitely comorbidity was as important as, or in the late phase of the patients after 65, this is the issue which decide the risk for mortality, and not the age. So until 65, the age. Above 65, definitely the comorbidities decide whether the patients will stay alive or not. Or this was the one I referred also yesterday, that we saw that 4 of 5 patients receive antibiotics in pancreatitis. And we wanted to ask why. Because it's not a contagious disease, you know, this bile or alcohol. So what we did, we looked at about how the disease developing the cytokine storm. And in a normal pancreatitis, you can see like when this was the negative bacteria, when they started an admission, day 1, day 2, what the doctors say, oh my goodness, the CRP is rapidly growing, let's start antibiotics. And after, when they see that it's decreasing, they said, wow, this was a good decision, I started the antibiotics. So you got feedback, but this is not. In a general acute pancreatitis, CRP leukocytes level going up until day 3 or 4, reach the maximum and start decreasing. So we sent blood samples for microbiology, and these are the ones which was positive bacteria and negative bacteria. It was very easy to see that the early rapid rising of CRP level have absolutely nothing to do with infection in pancreatitis. This is inflammation. And by this small data analysis, we could reduce the usage of antibiotics with 50% actually in there, and we wrote the guideline. The other important was we did a huge cohort of over 1,000 patients with drug-induced pancreatitis. We did it also in the electric system, and we actually realized that even the drug-induced pancreatitis is more severe than any other type of pancreatitis. You have a toxic, most probably because they have another underlying disease, they have other comorbidities as well, which you gave the drug, and when they got, you know, the pancreatitis. But sometimes you have to give back the drug again, because you have to treat, for example, a hematology disease or one thing. So how to give them? give them on the same dose, smaller dose, not to give them. So we also looked at the articles where they gave in the same dose, and here is the rate, and in a decreased dose. So we could have a very clear guideline. If you have to re-challenge the patients with the drug you believe induce acute pancreatitis, what you do, you need to start giving back in a lower doses for the patients. Or the other one was about the metabolic syndrome, the metabolic component. We were also see that how many diseases are strongly affecting on the patients. And now sometimes we can see that they have hypertonia, they have a slightly elevated triglyceride level, they have a diabetes, they have an overweight or obesity one, and these all together going to induce pancreatitis. So many times we can't see a single factor, but we can see multiple factors, and we could see that, for example, hypertonia really elevate the risk for pancreatitis. The another thing, for example, we looked at the triglyceridemia, which is definitely dose-dependently effect on it. After that, we started the elephant study, eliminating of fatty acids from the blood, because this is definitely strongly depend on the doses. This is the range for 11, and this is for 22. And if you see, if the triglyceride level after 11 going up, the severity of pancreatitis and mortality is really growing. The other issue is about the early CP. This is, I referred that after 3 pancreatitis, now we call them early chronic pancreatitis. If you look at the probability of pancreatitis after the single attacks of pancreatitis, if you look at the cohort who had the first pancreatitis, almost 0% the chance that the patients had chronic pancreatitis in the past. If somebody had a second attack of pancreatitis, for this cross-sectional cohort, you see 1 patient with chronic pancreatitis. But after 3 or more, you can see that if somebody had 3, already 16%, and after 4 pancreatitis, almost 50% the chance that you have chronic pancreatitis. So now we have a nomenclature that for those patients who had 3 pancreatitis with no morphological alteration, we call them early chronic pancreatitis. Now we will write a huge manuscript about currently our cohort, about how different these kind of diseases. We also looked at the glucose level. So currently in our unit, we give continuous insulin for every pancreatitic patient because they so change the glucose level. So we are not giving subcutaneously insulin. If somebody coming and going above 10, the glucose level, we start giving insulin by a pump. And this is the only way when we can set it from 5 to 10 about the glucose levels, because sometimes the beta cells at the early phase, they are injured, but after the 3rd day when the cytokine storm is gone, they come back, and if you give the insulin not in a controlled way, they can have hypoglycemia, which is actually just elevate the necrosis. This was the one about the albumin level. We clearly saw that albumin level, this is below 25, this is below 20. So albumin level below 25, you can see that highly elevate the risk for severe pancreatitis and mortality. So in my unit, if any patients after 25 millimolar, the albumin level dropping, we immediately start albumin. So all of our decisions, when a student asks me, why 25? I immediately can answer. Why we give glucose that way? I can answer. In the past, when I was a resident, I was taught, this is how we are doing it for 20 years. No, we have direct evidence by data why we do and what we do. Or this is the other issue concerning the enteral feeding. Why is it so good? Because this is the only enteral feeding early in day 21, which can decrease the early infection in pancreatitis. This is actually the only thing what we can do. We also looked at the alcohol and smoking, because plenty of times the patients doing both. And what the patients, okay, I can't put down the smoke. Do you have any evidence if I just smoke less, this will be helpful? Yes. So sometimes in a patient you can't achieve to put alcohol and smoke on the same time immediately. But you can have a master plan with the patients. Okay, now you're taking 1 pack per day smoke. Let's decrease with 1 every day until half a pack. Come back one month and let's look at how are you doing managing. Because you can see the data. If you can somehow even reduce the doses, the chance for you to save the pancreas is better. So, I mean, we have huge amount of data. And if you have a good quality data, plenty of things, the AI can replace you. And the AI can make decisions. So really, there is a time, but this is strongly believe on the data, because if garbage in, garbage out. So I looked at the deep learning, how to set the system up, whether to teach the computer. I tried several ways, but finally, without a good data, it actually didn't work. So we managed to make 3 AI system in pancreatology. One of them is the Easy app. I will show you. This is very good in a hospital because they can suggest you where to locate the patients, either in an ICU immediately or either in a normal ward. The Necro app helps you to decide what is the probability of necrosis for the patient. And we have also a Pineapple, which is children with abdominal pain, that this calculates you how much is the chance to get pancreatitis in children. Now we are finalizing it to a manuscript. We looked at over 1,000 kids with abdominal pain, with enzyme measurement and ultrasonography, and the computer can give you an estimation, because plenty of times for children they don't want to take blood test for them. So no, the doctor before taking the blood test have an app which suggests them this is a high risk or a middle risk or a lower risk. So, but all of them you need really, really good database. So I just would like to show you the Easy app. It's available on the net, so anybody can go there. If you're in an emergency unit, if you have any data, you can immediately can an estimation. And of course, this is why do we need a model? Because if you have the different scoring systems, there are plenty of troubles with it. Well, the first one, the Apache one, is absolutely a non-specific one. The Ranson and Glasgow score the best, over 90%, but they need over 30 parameters, including arterial oxygen. I never seen in my entire life a single unit on the globe which actually in the ER unit they calculated Glasgow score. So, and if I go on, it was definitely needed to have a project, and we started it in 2015. We called it EASY, Early Achievable Severity Index, which doesn't matter what kind of parameters you have, you put it to the system and they will calculate it. But very importantly, in the first 6-12 hours in the ER unit, so this is, we haven't followed the patients on it. So the whole cohort were from 12 countries and 1,184 cohorts. And of course, we had a validation cohort as well. And these are the parameters. Any of these parameters you have, you put in, doesn't matter you have 5 or 12, the system will calculate for you. And this is, of course, you have to train the system. This is when the multidisciplinary things come. We have a brilliant AI mathematicians. This is the model. Actually, luckily, I don't understand a single word on this slide. This is what the mathematicians do. So this is their job. So we have from the technical university a brilliant mathematician we are hired. And this is how when the system learn, and the AUC is just growing. So as many as data you have, as better as the system will be. And this is, of course, there are places where the system doesn't work well, but in couple of situations, yes. So for example, here is the app. Here is, for example, one patient. You can see that this is not only suggesting that 7% only the chance to have a severe pancreatitis, but writing out the parameters, how the system calculated. So it's very good for education. And you can see the confidence interval is very slow. So you can be very, very sure that these patients will never have a severe pancreatitis. You have the opposite. Although the patients look well, here is with 94% the chance, which very close action. So these patients immediately need to transfer to the intensive care unit, because there's a huge probability to have an organ failure, and it's the best if they are there. And of course, none of the systems are good for everything. There are patients when even the computer can't guess like put a 50% in the middle and put the system. So here is the test. We looked at the Bishop score, which is usually currently looked at for the patient, and the EASY score. And if you look at in the highest category about the final found of severe pancreatitis, this system can find the severe pancreatitis in much better OC than actually an earlier one. So, and this is, you can use it, this model. So if this suggests that the patient has really a high risk for pancreatitis, going to the ICU. If not, they can go into the normal ward. And this is the other study which let us working, because we followed these 2,300 patients for 8 years after they were the ward, and we looked at the post-AP mortality for this patient. As you can see, this was the cohort of 3,250 patients. This is what the computer calculated and everything. So you can see that this is a general pancreatitis cohort with around 3% mortality. And what actually at the very beginning showed us that this is a normal, the black one, the normal population mortality. So if somebody has we asked it for the National Statistical Office. So somebody who had acute pancreatitis here, this is the chance for mortality. So if somebody had acute pancreatitis and left home, they have 2 or 3 times higher chance to die. But the real amazing data was that the average percent was 3% for the patients in hospital to die, 3%. Which is, we know that this is the pancreatitis now. However, in year 1, at home, the patient has almost 2 times higher chance to die than in the hospital. This was I think, the real data which led the whole study published on gastroenterology on the cover page. And if you look at the years really in year 1, when the patients are most affected, and if we looked at year 1, which months are the highest the chance, the first 3 months. So usually in pancreatitis, not the in-hospital mortality which should count, but the 90 days mortality, which really important. But we learned it from cardiology and neurology that this is how important is the post-period. But in acute pancreatitis in the past, we had a romantic idea that the patients go home, one single pancreatitis, no trouble, they can live forever. No, they are really in danger. And after we looked at what are the population which are really in high risk, and now we will have another app for the doctors in the hospitals. You put the data, and when you discharge the patient, this will tell you about the chance to die. So if you can see, one of them was definitely the age, which is really affected. You know, this is a Kaplan-Meier about the survival rate. The other factor definitely was like diabetes. If the patients had diabetes, they had much higher chance actually to die at home. Comorbidity, you can see the curve of the survival curve. Lipidemia didn't come out because you had not enough patients there. And after we looked at in the anamnestic data, hyperlipidemia was also one of the signs for that. Concerning the other factors, you could see a couple of things, a tendency, but because we didn't have too many data stratification, we couldn't make like a conclusion of it. But if you look at the severity, this is the severe pancreatitis, the moderate one. This is local complication, necrosis, organ failure. So any of these had the patients, you definitely need to ask the patients to come back to you within 1 month. It's all patients coming back for our ambulance after a month. So this is the first 90 days mortality. This is the risk for severe and moderate pancreatitis, and 3 to 12 and 1 to 8. And the other fascinating data was we looked at the cause of death. Why these patients actually die. And if you look at, for example, this one, if the acute pancreatitis, this is the underlying disease, had like local complication, the highest risk for death was sepsis. Because if you send the patients home with fluid collection, they have a chance to have some bacteria and they can overgrow. But those patients who has, for example, cardiac comorbidity, the chance to die, they have cardiac issue. We now will start within a couple of weeks a new observational clinical trial when we will measure ECG, everything, ultrasonography for patient during the course of pancreatitis and after pancreatitis. But the other very interesting data was the cancer patients. Those patients who had cancer underlying disease, doesn't matter it was a prostate cancer, lung cancer, they actually speeded up. And the malnutrition, the cachexia, growed up. We all know that, for example, TNF-alpha, the earlier name of TNF-alpha was cahectin. This was what Bruce Beitler discovered. So because they found out this cahectin molecule in mice, in cancer mice, that they found this kind of molecule, and after they realized that this TNF-alpha not only play an important role in cachexia, but after also in inflammatory diseases in IBD and autoimmune diseases. Therefore, actually, most probably after acute pancreatitis, due to the big cytokine storm, this will actually speed up the malnutrition for the patients and they can have cachexia. Now we have a follow-up of 650 AP patients for every year for 6 years. This is the Guyash Plus study we are doing, and we will measure the inflammatory markers for that as well. So how it can change actually these data, again, the policy, this is definitely that now we have to have a closer surveillance for those patients who had cardiac disease, severe disease course, or pseudocyst when we discharge them. We definitely need to ask them within a month. We need to have a follow-up plan. We need to include for clinical study the post-discharge mortality and the evaluation. So I told you that we, in the last 30 years, this was my career in pancreatology so far, we really had lots of the Hungarian pancreatic study group, lots of articles, but all of them were data-driven. So without the data, without structured data, you can't make really good articles, and if you don't have biomedical samples also. And this is what I usually say, that curiosity fuels progress. You don't need to ask very difficult questions. One of the question was, you saw yesterday that we have gynecologists, orthopedics, and so on. So the gynecology head of department in Peter, let's do some gynecology pancreas study. Oh my goodness. So how can I find the study? But it was very easy. Pregnant women can get biliary pancreatitis. So we know that in mild pancreatitis, we take the cholecyst away during the index admission and the last. But what should we do with a pregnant woman? So I always try to push the surgeons even and the gynecologists to take away. Sometimes I could, sometimes I couldn't convince them. But do we have any evidence for that? So we said there are so many questions about whether this is safe, what will happen with the fetus, whether what's happening if we don't take away the cholecyst. Is it dangerous if we take it away? So we made an international survey. We started last year, and we called the BORN study, which will finish within a month, and we will send it most probably to a high-profile journal for publication, and these are the societies which were involved. Here are the institutions which provided actually valuable data to the study. So here we collected 85 pregnant women with biliary pancreatitis. This was the age distribution of the women, and this was the weeks of pregnancy at the time of the index of pancreatitis. But if you look at this part at the latest phase, when the abdominal pressure was growing, that the stones start going with the choledochus, it was a higher chance. So if you look at the curve, definitely this period were the women more affected and not in the very early phase of the disease. So this is definitely the pathophysiology, that if a woman has stones, when the pregnancy going further, the chance to get biliary pancreatitis is going higher. This is the weeks of pregnancy in other curve as well. So we looked at that. This is the number of previous pregnancy. These were exactly the same like in other cases. And a couple of % of women had CP and diabetes. So this is the previously known symptoms. And this is very interesting. 56% of these women had symptoms before. So why the cholecyst stay there? So sometimes, you know, we say, okay, we have the stone, we don't carry it, it's okay, I have just small symptoms. 56% had previously symptoms. And how long the symptoms is known, and many of them know before pregnancy. So this is very important for women. If you have symptoms and you are young and you have a biliary stone, take it away, because during the pregnancy you can have problems. So actually this is when we looked at this 85 women, there were 1/4 had choledochus stone, so we needed to do actually ERCP for these patients. And actually, this was another interesting thing, that those who had smaller stones, many small stones, the probability of getting pancreatitis was higher. So smaller stone, of course, if you have an abdominal pressure is help. So this is like the cholangitis, cholecystitis, how many women needed antibiotics, and how many had severe and actually local pancreatitis. So the other curve is that during this kind of biliary pancreatitic women, the HELLP syndrome, eclampsia, fetal mortality, and the preterm birth, if you look at the whole range, this is like very similar to the ones without biliary pancreatitis. The only issue was the fetal mortality, which we found higher than a normal one. So we asked the question, the first very specific question, whether in mild biliary pancreatitis, what's happening if we take away the cholecyst and not take away? We wanted to look at the effectiveness and safety. And this will be very big evidence again. So if you don't take away the cholecyst, within a year, the possibility of readmission during pregnancy or within a year at home is 28%. The chance to get recurrent pancreatitis within a year, 17%. And also the cholecystitis and cholangitis. Guess what? We built the other 11 women who had laparoscopic cholecyst, and we were surprised that none of them had recidive. Do we need more evidence for the case? No. So this is why we do. It's a very easy question. Nothing like serious molecular biology, genetic question. Just a simple question. You can do only good quality patients care if you collect data, you analyze the data, and use the data for decision makings. This was actually the preterm birth. Didn't change at all the preterm birth. So this was not affecting the outcome of the pregnancy. This is actually how many children needed in neonatal intensive care. There were no patients in this population. However, this one was the one which actually made us a little bit worried about the preterm mortality. The fetal mortality was here like in 2 cases. So we need, it seems a little bit complicated now that the red is, at the time, this is the weeks, the 40 weeks, the time of the pancreatitis, the blue one, the type of laparoscopic cholecystectomy, the black is the fetal mortality, and the delivery is the other one. So look, this is like those patients who had cholecystectomy. You can see that only a couple of them, had, later, this is the time of cholecystectomy. Most of them had, immediately after pancreatitis. You can see that there were 2 fetal deaths, but all of the fetal deaths happened only if the pancreatitis occurred within the first 8 weeks. After the first trimester, neither of the pancreatitis when you had the cholecystectomy had no problem. So we can see that the second and the third term doing the cholecystectomy definitely not harmful. But when we looked at these are the patients who didn't have cholecystectomy, and this is who had cholecystectomy. So in this case, the patients had pancreatitis, cholecystectomy, and the week 6 the baby died. However, this is as well, the baby died in the 15th. But in those patients where they had no cholecystectomy, they still could die. So we had 2 fetal mortality without cholecystectomy and 2 with cholecystectomy. We can't make a conclusion at that stage whether they any effect of the laparoscopic cholecystectomy on the mortality or not. But this is very important curve. If you don't make the cholecystectomy, the disease coming back in the late stage of the pregnancy. So they can get the second attack, either in the last weeks or after the first year when they had a baby. So after we ask another questions, there is a higher risk for post-surgical complications. We had no higher risk. So at the end of the day, what actually we could see that in this pancreatitis, really the pancreatitis injures the fetus, that's for sure. The recurrency, the risk of recurrency pancreatitis is 2 times higher than in a general population. Cholecystectomy completely prevents the recurrence, and this is the major issue, and this is definitely safe here, and no difference in the early or postoperative complications. So the final conclusion, again, you can use it immediately when you finish the study. So this is what I love in the CTM, what I showed yesterday, that whenever I do the study, I finish, I go to the department and can use it. So now I have a data to show to the surgeons when I go them that this is, I really want the cholecystectomy for these women. So I just can tell that questioning fuels curiosity, curiosity fuels discovery. So you always have question in the department. Let's make a system when you can collect data and you can go back. So actually, yesterday I was completely impressed about what I saw in Yash. So we have a huge amount of Nobel laureates we are connected. So actually in December, Martin Calif, who discovered the gene fluorescence protein, will come to Szeged, to my town. So yesterday evening, after the dinner with the rector, I wrote an email to Martin whether he would be interested to make a 50 years lecture in Yash in December, exactly on the same day when George Palade made in Stockholm the presentation, and he already replied. So of course we need to set up the whole program, but this could be like a present of my visit that most probably I will be able to bring a Nobel laureate to celebrate George Palade's Nobel Prize in December to Yash. So I really, these dates now, book your diary. There is a high probability in saying in mathematical model that somebody will come. And I'm really thankful for the team, because without the young people, the young PhD students, we couldn't be able to do any kind of science. So I really thank you very much for your attention. I already love Yash, and most probably in December I will come back also with Martin to celebrate George Palade's Nobel Prize 50 years anniversary. Thank you.
Thank you very much. Very nice surprise. Thank you for that. I also have to say for you and for everybody, there is a prize of the Pancreatic Club.
Yeah.
And what is the name of that?
Palade, yeah.
Right.
The highest prize for pancreatology by the IAP, the International Association of Pancreatology, George Palade.
I think there is a time maybe in future, maybe a Romanian will take that prize also.
Let's go for it. I mean, everybody is capable in this room. I am 100% sure.
Okay, so thank you very much for your nice presentation. And I think your presentation is open for questions. Please.
First of all, thank you very much for your excellent presentation, Professor. I would like, no, I have no questions, but just a little comment regarding the acute pancreatitis related with pregnancy. I know I have a little experience in this field, and I can say that the second trimester is the ideal period to do cholecystectomy in pregnant women to prevent biliary pancreatitis. In the third, I think it's too late, and if the pregnant woman had episodes of acute pancreatitis before pregnancy and she neglected or she didn't want to operate, it's not good. It has to be monitored and present to the gynecologist and gastroenterologist, because it is a straight and a relationship between these fields. And teamwork is very important to have a good outcome for the pregnant woman. Thank you.
Thank you very much. I absolutely agree with your comment about the second, but this is why actually this is a very good example. Can we come back? Because I just would like to come back for... So this is actually, your comment is, in the second phase, it's absolutely very important to do it. However, this is why we do science, to understand what's happening in the third trimester the women have. What is the probability of coming back, you know, the pancreatitis? So if I just jump here for this, I hope I will show you evidence with this curve, and we are immediately there to answer your question. Here, that those women who in the third trimester, and this is the recidive, after the 28 weeks, they didn't get the cholecystectomy. You know, the disease came back again within a year, if you see that. Even when they are in a 3 months old baby, they don't want to be in the hospital. So even in the third trimester, if you don't do for example, here on 27/8 or that's, the disease easily can, you know, coming back. So when we looked at the data, my suggestion, not my suggestion, sorry, the data suggests, I think this is the best way, irrespectively it's coming in the second or the third trimester, let's do it. Because we had no more preterm births, the baby were completely right. So this is, but your observation were brilliant that in the second term, it's safe, but this is what I'm mentioning. And what was really fascinating, that these women, I showed you, had no pancreatitis earlier, but had symptoms. So even if a woman have symptoms about due to their stones, they should go to cholecystectomy, irrespectively whether they had acute attack or not. But thank you for your comment.
So that means the gynecologist,
yes,
when making the first evaluation of the woman, of the pregnant woman, should see if the patient has gallstones,
yeah,
and symptoms.
So if a woman going to a gynecology, I would like to have a baby, could you make a checkup? Oh, you have a gallstone. Do you have symptoms? Yes. So before you go to have a pregnancy, let's go and take your gallbladder out. This is an important message.
Okay, thank you. Other questions, please? Stefan.
Hello, excellent presentation and very inspiring. I don't know if this is working. I have a few questions.
Very good.
If I have to summarize, how do you deal it with surgeons, radiologists, and anesthesiologists in acute pancreatitis? So the radiologists are telling us in the first 72 hours we should do the CT scan because the modifications are not yet installed, and usually in the ER department they are not doing any CT scan. This is the first question.
It's his duty and the hospital's duty to make the radiologist to make it. This was the same when I went to Page and the Semmelweis, they didn't want to do. And
yeah.
I said, let's look at the guideline. Evidence 1A in the guideline that the pancreatitis must be visualized. We had so many patients, even in pancreatitis, it's turned out that besides their pancreatitis, they have like other diseases as well.
There is an internal protocol of the hospital.
Not only no, yes.
Yeah.
Before it was not an SOP, but we have the international guideline. So if you look at the international guideline, if it's the pancreas has to be visualized to make the etiology. So I mean, of course, it's not coming by chance. So you have to have a word with the GI leader, with the hospital leader, that we need to visualize the pancreas. Okay, first ultrasonography, all guidelines saying you have to start with it. But if you can't see with the
I totally agree.
gas,
I totally agree. That's why I asked the question.
So
Yeah.
that means, sorry, if the radiography, the ultrasonography is saying that I cannot see the pancreas,
see in these cases.
In
Yeah.
that case, a CT have to be done at admission.
Yeah. Yeah.
That's the
yeah.
conclusion.
Yeah.
So it depends.
That was the question. Yeah.
Yes, who is seeing at the ultrasonography, he has to
So
give
some
the
of the
results.
patients of this actually had already bowel rupture, so there were gas inside them and they had to be operated. And the pancreatitis etiology was actually like an ulcus disease, which actually just opened up and so on. So you must know the etiology to get the best treatment.
Yeah, totally agree. The second question, we have a small ICU unit, and it's very hard to send there the acute pancreatitis patients, which are the...
It's the same.
The same. Which are the most urgent criteria which you use to do that?
Actually, there is also a very clear guideline
Yeah, I know.
about it. In the
But you can't respect it
But
with
you
the
have
number.
to make the. I mean, I usually when I teach the students, I say that the only thing what you need to understand, the pancreatitis is completely different than like other disease like bleeding or so on. Because some patients go into the ER unit with the bleeding, you start the hemoresuscitation, everything they can better from 0 point. If there is a stroke patient, you do the thrombectomy, they can better. Pancreatitis, due to the cytokine storm going on the day 72, irrespectively your treatment, the patient's going down in the unit. So if the earlier sign, even the patients, I had like 3-4 patients who were working when come in and we lost them within 24 hours. Even they were on their own legs when they come in. So what you could do, what we did, we established a high dependency unit, like sub-intensive unit and our center. So we have 6 beds with monitor and staff. So having a high dependency unit is in every hospital to elevate the number of them, like for GI bleeders, for acute pancreatitis. This can be the solution because, of course, it's a luxury to have, and sometimes you can't pay enough, to have more beds in an intensive unit. But, for example, in the GI unit, should have a strong, like 6, 8, or 10 beds with high dependency. And this is for GI bleeders, like hepatic coma or something which is going the patients to have it.
And for the surgery, there are any criteria? Of course, there is acute abdominal compartment syndrome, but any other criteria or no?
God save the patients from the surgeons.
So
this
no.
is my message from pancreatitis. Except this abdominal pressure, we had 1,075 patients, only 2 had surgery. And so in acute pancreatitis, it's almost, you have to wait. Even there were in a randomized clinical trial in the New England Journal of Medicine, which looked at infected. Even if the pancreatitis infected in the first 4 weeks, they randomized the patients. One of them were only controlled with antibiotics. Even they knew that there were gas bubbles, and the other were put to the surgeons. And the final outcome in the mortality were exactly the same in both groups. New England Journal of Medicine last year, a huge study showing. So even if it's infected, if you can control with 3-4 different antibiotics and antifungal therapy, it's still better until you have a demarcated one, so you have like a wall of necrosis. If there is only an acute necrotic fluid collection, I just can ask that don't touch it if it's not life-saving. If there is a bleeding, no question. But even infection was shown in New England in a randomized clinical trial, but the patients didn't get benefit.
Okay, thank you.
Okay, in high dependence unit, in your unit actually, who is seeing the patient? Is the gastroenterologist, or maybe can be seen together with the anesthesiologist?
Unfortunately, only gastroenterologists so far, but when I was in the University of Page, what they did, at the ICU unit, there were doctors in the healthcare who had gastroenterology consult exam first, and after ICU. There were some with cardiology plus ICU. So I think the best would be, if you have so many young people, gastroenterologists, go to the intensive care, learn it, and coming back being a gastroenterologist and having ICU knowledge. At the University of Page, there are 3 gastroenterologists, and they run the HDUE unit, who actually had the consultations like like ICU. So in my opinion, a good GI unit, this is what I will try to establish in Budapest. We will have gastroenterology radiologist, gastroenterology ICU specialist, gastroenterologist pathologist. So have 2 exams to have a multidisciplinary knowledge.
Okay, thank you. Stefan?
Hello, Professor. First, thank you for the excellent presentation. It's wonderful to see how you put data to good clinical work. And I was wondering, as I'm performing endoscopic ultrasonography, I often find cases with the patients that have some small modifications of incipient chronic pancreatitis or EUS. However, they do not fit the criteria for chronic pancreatitis. And these are mostly incidental findings as I search for the bile ducts or for other pathology. But some of them also have had acute pancreatitis. And I was wondering if you perform in your clinic US for chronic pancreatitis, and if these small modifications could perhaps predict recurrent pancreatitis or anything like this.
Brilliant question.
Could this
I wish
be
I
used
could.
Clinically?
Brilliant question. I wish I could answer it.
Yeah.
So this is why we need registries. Let's open up an EUS registry for pancreas. What we know, for example, if you see fatty pancreas,
Yeah.
it elevates. No, we just published 2 months ago. It elevates 6 times the risk for pancreatic cancer, 6.5. The risk ratio for pancreatic cancer. So we already know that they are under danger. Most probably, if you already visualize the problems, most probably on this group, the recurrent rate will be higher in this which not, but this is just hypothetical. These are why we need registries and data collection. Thank you.
Thank you.
Radu, please.
Thank you, Professor. Excellent presentation. My question is regarding the first part of the presentation, more exactly about data management and data collection. As young researchers, we sometimes feel like digging after data with a shovel. So it's something really hard for us. Please tell us, how did you manage to put the system? What were the obstacles and what were the solutions?
Okay, we had thousands of obstacles and step-by-step solutions. So when I was in 2011, let's start the registry. Okay, we have no really money. How to start it? So I went to pharmaceutical companies, to Solvay, actually, who had the crown, and after I went to who was the one who had the Pancreatitis, and I asked money from them, like 2,000 euros, and the money was like 5,000 euros per year. So I paid first to the nurses to put the data into the system, and for one patient we paid like 5 euros, 10 euros to the nurses everywhere. So this is how I started. I asked money from pharmaceutical companies. I started down, and I paid for one IT guy to make a very basic electronic system. This was the start. And this actually caused our first paper with 600 acute pancreatitis, which we published, Blossman and Noyes, 260 citations in 2016. And because we could publish the first papers, we could get a big grant later on, which was like really a huge EU grant, which contained approximately 2 million euros for 5 years. So we bought actually a US system, the newest one, and now I immediately hired 9 clinical administrators and an IT company to have a really now comprehensive and a good IT. And after, when they put them in the data, so on, after we again applied for grant, so we started almost for nothing, and we step by step, small steps resulted. So I really have no solutions. Thousands of obstacles, but the only issue is that it's your decision how to keep it going. If you keep it going, you can do that. The only issue is what does not work if you retrospectively try to collect the data. Because if you start like what we started, there is so many missing data, so the artificial intelligence programs will not be able to use it. So you need to have enthusiasm and resilience to get it, and finally you will find the sources.
Thank you.
A question from my side, if it's possible. Actually, the patient with acute pancreatitis, we saw that mortality is in the majority of mortality in the first 3 months after the discharge. Actually, what you are doing? Ask the patient to come back if even it's absolutely perfect at 1 month or 2 months, or what you are doing?
Yeah. Currently, every patient discharged have to come back after 1 month. For several reasons. First of all, we could see that if they, for example, alcoholic, and we give a brief interventions by ourselves about motivational speech and so on, we control the gamma GT level and above. So if the patient knows that the patients will come back, they behave a little bit better than if they are released. So 1 month or if it's a bile induced, we try to make sure that the surgery will happen. And not, it's fine, the patient is a person. So every patient after 1 month coming back for outpatient control. However, those who had local infection and you treated with antibiotics, but when you sent home they have still fluid collection, we ask them to, we take out the antibiotics, we wait 1 day without antibiotics, and if the CRP not starting elevating, we discharge the patients. But this patient, we ask 2 weeks after that to come back. So those who are in danger for sepsis, I ask to come back after 2 weeks, the others after 1 month. We hope that the study we will perform now to understand will ask you, because if somebody asks me, this is enough to come back after 1 month and after this, I don't know.
That was the second question.
Yeah,
Do you have evidence for that this is working?
No, this is why we need, because we have a hypothesis, like when it's good, for example, to take away the cholecyst in pregnant women. We have a hypothesis, and sometimes it's logical and good, but nothing can replace the real data.
Okay, thank you. Please.
Just one, not a question, just a statement. So maybe what you told us today would relieve the pressure. I'm a surgeon. Would relieve the pressure from our colleagues from gastroenterology to admit in surgery basically almost all the patients with severe acute pancreatitis. So I think this would be a new way to start to continue our collaboration. So we admit the patients with high Balthazar score, with need for ICU care, but in surgery.
This should, in my opinion, no acute pancreatitis should be treated by gastroenterologists.
Thank you.
From our point of view, it's not necessary that we want the patient to be operated. We don't want that. But the access to ICU, it's much easier. And practically, that's the problem. Because we need assistance, we need more help, and from the beginning, and that is very important.
But I would like
from the colleagues from ICU. We have it, but still we want more. On the other hand, we want more help from radiologists. We know that sometimes it's important to have the CT at the beginning. Well, most of the time, and people from casualty, radiologists may refuse us at that moment.
The issue is that I still would suggest to have a centralized patient care. So we had a very clear data, and actually published in the Journal of Gastroenterology and Liver Disease, the Romanian journal, we published a couple of years ago, concerning that the centralized patient care is always better. So I think if the intensive care specialists are understanding the acute pancreatitis one, it should be no problem to get access for you. But I definitely would suggest, concerning the management of acute pancreatitis, to have one department to be. It's better for science, better for high volume of patients number and so on. And concerning the radiology, on the other hand, I saw in the past plenty of CTs just to monitor the patients is get better. Oh, the patients had big necrosis, the patient's getting better. Let's repeat it to show that the regression of the disease. No, you don't need. So there is very clear the guideline. First, the guideline, acute pancreatitis, you have to visualize in the first 24 hours. That's very clear. The the second CT need only if the patient's conditions worsen or the treatment doesn't work. This is the only. Just repeating, showing that the acute fluid collection is decreasing, you don't need, because you need a non-invasive method. So if the patients had huge acute fluid collections, but absolutely no problem, no CRP elevation, no amylase elevation, no lipase, the patient is well, you don't make intervention, you send the patients home and control it. So CT needed to be repeated only if the patient's condition worsen. And I saw plenty of times that we use CT plus is just, just to check whether the patient's improving. But the clinical picture is improving. You don't need to retake the CT.
Other questions?
Do you have dedicated surgeons in your center?
Yes, we have pancreatic surgeon.
Okay, so only dealing with these cases.
Yeah, but
Surgeons on call.
Yes. We have special pancreatic surgeons. I mean, with the surgeons, the biggest always fighting about the mild biliary pancreatitis, because when it's mild, the patient shouldn't go home from the hospital without going for cholecystectomy and after go home. All surgeons always want to have a 6 weeks, 8 weeks later date, but if it's a mild, it's a must, because otherwise there is a 10%, this was the Poncho trial published in 2015 by the Dutch pancreatitis study group very clearly. If it's a mild biliary pancreatitis, you do the on-admission cholecystectomy, so index cholecystectomy, when the patients are done, you do it from 10%, decrease 2% the recidive attacks 5 times. So every mild biliary pancreatitis cholecystectomia should be during the index admission. We can manage 70-80%. Now I am super happy about it. But I don't know here, how difficult it is to make this kind of, sometimes the patient's coming on Monday, the pancreatitis over on Thursday, on Friday there is an operation, on Saturday the patients go home. This would be the best clinical practice.
You said that you have a patient coordinator in your unit. What's his role exactly? And is it a nurse or it's a clerk or what?
It's not especially nurse. You don't need, but who is asking back the controls, calling back that when you went back, so like a telemedicine way as well. Some patients doesn't come back for the 1 month control. Around 20%, we still call them back. That how are you? Do you have any problem? Or so on. So the patient's coordinator is, as in this name, it could be anybody else. So anybody can do this job. We usually take somebody in a health sciences, either a BSc or an MSc for that position, who something understand about the diseases, and they are managing the cancer patients and the other ones. So we have a hotline for the patients. They can call us at any time.
At the hospital level, do you think that could be feasible, or how do you think? Or it have to be a smaller scale, actually?
Yeah. I am not sure what, I mean, it's every hospital different, because the budget could be different. But one thing is for sure, that you need to collect KPIs, because, for example, I don't know how the hospital budget is handled, but, for example, you can save money with an evidence-based patient care. We show very clearly, if you do that way, that you do everything, just 40% antibiotics, going home and so on, you can save 25% of the money. So if you do the evidence-based care, it may be in one side a little bit more expensive, but for example, you use less antibiotics. So if you collect the data, so we wrote an article in UEG journal asking that whether we call it implementation manager. So I think first there should be implementation manager, which role is to be an officer to check whether, for example, one KPI, how many patients receive antibiotics in acute pancreatitis? Look that. The director sees 80%. Let's reduce it. I will check it in the next month. It has to be 40%, guys. you immediately saved huge amount of money for that. Or, for example, we measure triglyceride for all patients on admission and hemoglobin A1C, because this can also decrease it. So these moments decrease the length of hospitalization like more than 1 day. If you have many patients, they are in the hospital 1 day less, this money can be saved.
Thank you.
The problem is that in Hungary, in general places, they don't collect KPIs, key performance indicators. Like if I ask the pathology, what is the average days of the pathological samples examination? They can't tell it because they don't check the data. Ooh, it's too long. How can I bring it smaller? So there are no set of priorities. Nobody checking, how you treat the patients, whether it's in an evidence-based or not evidence-based guideline. I think this is what definitely in Eastern and Central Europe it's missing. In Western Europe, in the US, the insurance company do not pay the bill if it was not with an evidence-based way.
Thank you. Other questions? If not, thank you.
So I have we still have a couple of books. Yesterday they gave the talk concerning the CTM program. So we would be very happy if anybody in the room
I
would...
looked to that. It's very interesting. It's about the Translational Center in Budapest. So who is interested?
If somebody is interested, we still have
maybe
a couple of books. If you look at, you can with your QR code going there, you can recheck the presentations. If anybody interested in here, we are more than welcome anybody for 1 year in the center. They can come back and they can learn these kind of methodologies. And thank you for the privilege of giving the presentation here.
Thank you very much. Thank you.